Exocrine Pancreas. Question and answer session. Welcome to today's podcast, where we discuss the main aspects of surgical management of the exocrine pancreas. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of the exocrine pancreas. Pause the podcast after each question to attempt answer. Let's begin. Cystic neoplasms of the pancreas. Question: what is the prevalence of pancreatic cystic neoplasms? Answer: pancreatic cystic neoplasms are increasingly recognized and are second only to pancreatic adenocarcinoma. Question: why is treatment decision-making complex in pancreatic cystic neoplasms? Answer: treatment decision-making is complex because it requires balancing cancer prevention with the risk of overtreatment. Question: what are the major guidelines for the management of pancreatic cystic neoplasms? Answer: the three major guidelines for the management of pancreatic cystic neoplasms are the American Gastroenterological Association, 2015, the International Association of Pancreatology, 2017, and the European Study Group, 2018. Question: how are pancreatic cystic neoplasms broadly classified? Answer: pancreatic cystic neoplasms are broadly classified into non-mucinous and mucinous types. Question: what are examples of non-mucinous pancreatic cystic neoplasms? Answer: examples of non-mucinous pancreatic cystic neoplasms include serous cystic neoplasms and solid pseudopapillary neoplasms. Question: what are examples of mucinous pancreatic cystic neoplasms? Answer: examples of mucinous pancreatic cystic neoplasms include intraductal papillary mucinous neoplasms and mucinous cystic neoplasms. Question: why is classification of pancreatic cystic neoplasms important? Answer: classification of pancreatic cystic neoplasms is essential for determining their malignant potential and for guiding appropriate management. Question: how do different types of pancreatic cystic neoplasms influence management strategies? Answer: serous cystic neoplasms are mostly benign and usually do not require surveillance, while intraductal papillary mucinous neoplasms, mucinous cystic neoplasms, and solid pseudopapillary neoplasms are premalignant and require either surveillance or surgical resection. Question: what are the goals of monitoring pancreatic cystic neoplasms? Answer: the goals of monitoring pancreatic cystic neoplasms are to prevent malignancy, alleviate symptoms, and avoid unnecessary surgery. Subtypes of cystic neoplasm. Solid pseudopapillary neoplasm. Question: in which patient demographic is solid pseudopapillary neoplasm most commonly found and how does it present? Answer: solid pseudopapillary neoplasm is primarily found in young females between 25 and 35 years old and is often diagnosed incidentally or as a palpable mass. Question: what are the tumor characteristics of solid pseudopapillary neoplasm? Answer: solid pseudopapillary neoplasms are large, round, well-circumscribed tumors with a mean size of 8 cm and are located in the body and tail of the pancreas. Question: what are the pathological features and treatment recommendations for solid pseudopapillary neoplasm? Answer: solid pseudopapillary neoplasm is a low-grade epithelial tumor with a characteristic beta-catenin gene mutation, classified as malignant and requiring resection due to its potential for lymphatic spread, recurrence, and distant metastases. Question: what is the long-term outcome for patients with solid pseudopapillary neoplasm? Answer: the long-term outcome for patients with solid pseudopapillary neoplasm is excellent, with 95.6% of patients remaining disease-free. Question: what proportion of patients with solid pseudopapillary neoplasm present with locally advanced tumors? Answer: around 6% of patients with solid pseudopapillary neoplasm present with locally advanced tumors. Question: what proportion of patients with solid pseudopapillary neoplasm have distant metastases? Answer: 8% of patients with solid pseudopapillary neoplasm have distant metastases. Serous cystic neoplasm. Question: where are serous cystic neoplasms primarily located and which demographic is most commonly affected? Answer: serous cystic neoplasms primarily affect the head of the pancreas and are more common in older patients. Question: what is the typical clinical presentation for patients with serous cystic neoplasm? Answer: patients with serous cystic neoplasm typically experience vague abdominal pain, while weight loss and obstructive jaundice occur less frequently. Question: what radiographic features are seen in serous cystic neoplasm? Answer: Computed tomography scans may reveal central calcification with radiating septa, creating a sunburst appearance in 10 to 20% of cases of serous cystic neoplasm. Question: when is pancreatectomy recommended in the management of serous cystic neoplasm? Answer: pancreatectomy is recommended for cases where malignancy is uncertain or for symptomatic serous cystadenomas. Question: how does tumor size relate to symptoms in serous cystic neoplasm? Answer: patients with serous cystic neoplasm larger than 4 cm are more likely to experience symptoms and have a faster tumor growth rate. Question: when is resection of serous cystadenoma considered appropriate? Answer: resection of serous cystadenoma is considered appropriate for select patients who have large or rapidly growing lesions. Mucinous cystic neoplasm. Question: how is mucinous cystic neoplasm defined and what is its range of malignancy? Answer: mucinous cystic neoplasm is defined as a mucin-producing cyst tumor that does not communicate with the pancreatic duct and ranges from benign to invasive carcinoma. Question: what are the histological features of mucinous cystic neoplasm? Answer: histological features of mucinous cystic neoplasm include mucin-rich cells, ovarian-like stroma, and positive staining for estrogen and progesterone receptors. Question: where are mucinous cystic neoplasms typically found and how do they present clinically? Answer: mucinous cystic neoplasms are typically found in the body and tail of the pancreas and are often asymptomatic but may present with abdominal pain or a history of pancreatitis. Question: what is the typical radiologic appearance of mucinous cystic neoplasm? Answer: mucinous cystic neoplasm typically appears as a solitary cyst with possible fine septations and a rim of calcification. Question: what are indicators of malignancy in mucinous cystic neoplasm? Answer: indicators of malignancy in mucinous cystic neoplasm include eggshell calcification, larger tumor size, and the presence of a mural nodule. Question: can cross-sectional imaging differentiate between benign and malignant mucinous cystic neoplasms? Answer: cross-sectional imaging alone may not be able to differentiate between benign and malignant mucinous cystic neoplasms. Question: what is the role of endoscopic ultrasound and cyst fluid analysis in diagnosing mucinous cystic neoplasm? Answer: endoscopic ultrasound and cyst fluid analysis are essential for diagnosing mucinous cystic neoplasm and other cystic neoplasms. Question: what findings are seen in fine needle aspiration of mucinous cystic neoplasm? Answer: fine needle aspiration of mucinous cystic neoplasm reveals mucin-rich aspirate, high carcinoembryonic antigen levels, and low amylase. Question: how accurate is fluid analysis for diagnosing mucinous cystic neoplasm? Answer: fluid analyses offer accurate diagnosis in up to 80% of cases of mucinous cystic neoplasm. Question: what is the standard treatment for mucinous cystic neoplasm and its effectiveness? Answer: pancreatic resection is the standard treatment for mucinous cystic neoplasm and is curative in the absence of invasive malignant disease. Question: what is the prognosis for invasive mucinous cystic neoplasm compared to ductal adenocarcinoma? Answer: the prognosis for invasive mucinous cystic neoplasm is poorer than for non-invasive mucinous cystic neoplasm but more favorable than ductal adenocarcinoma, with a 5-year survival rate of 50 to 60% following resection. Question: what is recommended after resection of mucinous cystic neoplasm, especially for node-positive disease? Answer: adjuvant systemic chemotherapy is often offered after resection of mucinous cystic neoplasm, especially for node-positive disease. Intraductal papillary mucinous neoplasm. Question: what is the definition of intraductal papillary mucinous neoplasm? Answer: intraductal papillary mucinous neoplasm is a mucinous epithelial tumor that arises from the main pancreatic ducts, branch ducts, or both. Question: how has the diagnosis of intraductal papillary mucinous neoplasm changed with advances in imaging? Answer: the diagnosis of intraductal papillary mucinous neoplasm has increased due to the increasing use of cross-sectional imaging. Question: how is intraductal papillary mucinous neoplasm currently graded histologically? Answer: intraductal papillary mucinous neoplasm is currently graded as low, moderate, or high-grade dysplasia, and is classified based on the presence or absence of invasive malignancy. Question: what are the 3 subtypes of intraductal papillary mucinous neoplasm? Answer: the 3 subtypes of intraductal papillary mucinous neoplasm are branch duct intraductal papillary mucinous neoplasm, main duct intraductal papillary mucinous neoplasm, and mixed type intraductal papillary mucinous neoplasm. Question: What does branch duct intraductal papillary mucinous neoplasm affect? Answer. Branch duct intraductal papillary mucinous neoplasm affects only the small side branches of the pancreatic duct. Question. What does main duct intraductal papillary mucinous neoplasm involve? Answer. Main duct intraductal papillary mucinous neoplasm involves the main pancreatic duct. Management strategies for intraductal papillary mucinous neoplasm. Question. What factors influence the risk of malignant transformation in intraductal papillary mucinous neoplasm? Answer. The risk of malignant transformation in intraductal papillary mucinous neoplasm is influenced by multiple factors. Question. How are risk factors for malignant transformation in intraductal papillary mucinous neoplasm identified? Answer. Worrisome and high-risk factors are identified through international consensus. Question. Where are the factors for management of intraductal papillary mucinous neoplasm reported? Answer. These factors are reported in the International Consensus Guidelines for the Management of Intraductal Papillary Mucinous Neoplasm of the Pancreas, most recently updated in 2017. Question. What are the worrisome imaging features for intraductal papillary mucinous neoplasm? Answer. Worrisome imaging features include branch duct cyst size greater than 3 cm, enhancing mural nodule less than 5 mm, thickened enhancing cyst wall, main pancreatic duct size between 5 and 9 mm, abrupt main pancreatic duct caliber change with distal pancreatic atrophy, and lymphadenopathy. Question. What are the worrisome clinical features of intraductal papillary mucinous neoplasm? Answer. Worrisome clinical features include clinical pancreatitis, elevated carbohydrate antigen 19-9 level, and cyst growth greater than 5 mm over 2 years. Question. Where can a summary of worrisome features for intraductal papillary mucinous neoplasm be found? Answer. A summary of worrisome features can be found in Table 92.6. Question. What are the high-risk features of intraductal papillary mucinous neoplasm? Answer. High-risk features include an enhancing nodule larger than 5 mm within the cyst, main pancreatic duct dilation of more than 1 cm, and jaundice. Question. Which genetic mutations have been studied in intraductal papillary mucinous neoplasm? Answer. Genetic mutations such as NOS, CROSS, page 53, and mucin genes have been studied for their potential to predict malignant transformation in intraductal papillary mucinous neoplasm. Question. What are the current limitations of genetic analysis in intraductal papillary mucinous neoplasm? Answer. Genetic analysis of cyst fluid has not yet proven to be a reliable method for predicting malignancy or guiding surgical decisions in intraductal papillary mucinous neoplasm. Question. What tools are primarily used for predicting malignancy and selecting patients for surgery in intraductal papillary mucinous neoplasm? Answer. Current clinical guidelines remain the primary tool for predicting malignancy and selecting patients for surgical resection in intraductal papillary mucinous neoplasm. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.